Welcome to the deep dive. Today we're really getting into the thick of it with general anesthetics, or GAs. These are the drugs that, honestly, transform surgery from something truly terrifying, our sources call them horrible ordeals, into, well, often routine procedures.
That's absolutely the plan. We're aiming to decode these agents, the ones that give us this reversible loss of all sensation and consciousness, too. It's not just what they do, but, where in the brain and spinal cord they're actually working to create this very controlled, very specific state.
Right, because it's not just about sleep, is it? When we talk about a successful general anesthetic, there's a checklist. Our sources lay out 4 key features, 4 pillars, really, that define success. What are those essentials?
They really do form the core definition. First, and maybe most obviously, is the loss of all sensation, especially pain. That's paramount. Without that, it's just trauma.
Okay, number 1, no pain.
Second is what most people think of, sleep. Unconsciousness, essentially, but also deep amnesia. The patient needs to be completely unaware during the procedure and have absolutely no memory of it afterwards.
Makes sense. And the other 2 are more about the practical side of things, for the surgeon.
Exactly. Pillar number 3 is immobility and muscle relaxation. The patient has to be completely still, muscles relaxed enough so the surgeon can actually work safely. Any struggling, any tension, it compromises everything.
Okay.
And finally, number 4, and this is huge for patient safety, is the abolition of somatic and autonomic reflexes. We need to stop the body's automatic, potentially dangerous responses to the surgical insult, things like a sudden heart rate drop or a massive blood pressure spike.
Yeah, you can see how getting all 4 of those perfectly balanced with just one single drug,
Yeah.
well, that would be incredibly difficult, maybe impossible historically. Which leads to the modern approach, right? Balanced anesthesia.
It was a crucial evolution, really. Balanced anesthesia means using a cocktail, a combination of different drugs, both inhaled and intravenous. Each drug is chosen for its strength and hitting 1 or maybe 2 of those pillars.
Ah, okay, so you might use one for pain.
Exactly. One specifically for potent analgesia, another for inducing that rapid unconsciousness, maybe a dedicated muscle relaxant for that perfect immobility. The big advantage is you can use lower doses of each individual agent.
Which means fewer side effects, less toxicity overall.
Precisely. It's a much safer, much more tailored approach.
Looking back, though, before we had this balance, the history really underscores how desperate things were. Before the mid-1800s, surgery sounds just brutal.
It was. Speed was everything. Surgeons literally raced against the clock because the patient was awake, in agony. The change actually started, interestingly, with dentists.
Right, Horace Wells.
Horace Wells, 1844. He introduced nitrous oxide, N2O, laughing gas. It showed some promise, but its potency is quite low, so for major surgery, it often just wasn't enough. It failed to reliably kill the pain.
But then came the big one, the public demonstration in 1846, Morton and ether.
That was the game changer. Ether anesthesia took off worldwide pretty quickly after that demonstration. Then, just a year later, 1847, Simpson in Scotland introduced chloroform.
Which became popular, especially in Britain, for childbirth, I read.
Yes, largely because it wasn't flammable like ether and maybe easier to use, but it came with a serious downside, a significant risk of toxicity, especially cardiac problems.
So the move towards the kind of agents we think of today came much later.
Much later. The first major intravenous GA, thiopentone, wasn't until 1935. And then halothane in 1956 really ushered in the modern era of safer, non-flammable inhaled agents. That really set the stage for where we are now.
Okay, so let's dive into the core question. How do these things actually work? It's kind of surprising, isn't it, that even now, the precise mechanism isn't completely nailed down for all of them. We have all these different chemicals, different structures, but they all lead to anesthesia.
It is one of the enduring mysteries in pharmacology. The first real attempt to explain it was all about physics and chemistry. That's where the Meyer-Overton hypothesis came in around 1901.
Ah, yes, the lipid theory connection.
They noticed this really striking correlation, a direct link between how potent an anesthetic was and how well it dissolved in lipids, or fats, compared to water. That's the lipid-water partition coefficient.
So basically, the more fat-loving the drug, the stronger the anesthetic effect, which led to the idea that they work by dissolving in cell membranes.
Exactly. The lipid theory proposed that GAs didn't need specific receptors. They just sort of dissolved into the fatty lipid bilayer of the neuron's membrane. And by doing that, they thought maybe it expanded the membrane or made it more fluid, somehow disrupting nerve signals globally.
It sounds neat, and that correlation must have looked really convincing at the time. But you flagged a limitation. Why did science eventually move beyond the lipid theory as the main explanation?
And this is really crucial for mastering this. That correlation, strong as it is, mainly tells us how easily the drug can get to its site of action. High lipid solubility means it can cross the blood-brain barrier easily, it can partition into the neuronal membrane efficiently. It explains the pharmacokinetics getting into the CNS.
But not what it does once it's there.
Precisely. It doesn't explain the pharmacodynamics, the actual mechanism by which anesthesia is produced. Just because it can get into the membrane doesn't explain how it stalks nerve signaling.
Okay, so to measure that potency clinically, especially for the inhaled gases, the key metric is MAC, right? Minimal Alveolar Concentration.
MACE is the absolute benchmark in clinical practice. It's defined very specifically. It's the lowest concentration of that anesthetic gas in the alveoli, the air sacs of the lungs, that's needed to prevent 50% of patients from moving in response to a standard surgical incision, like a skin cut.
So it's basically an ED50 for preventing movement.
Exactly. It's a measure of immobility under surgical stress.
And what makes MA so useful, so reliable?
Well, for a given young, healthy adult, it's remarkably consistent for each agent. It is predictable, though. We know it decreases with age, quite significantly after age 50, so anesthetists need to adjust the dose down for older patients. But most importantly, MAC values for all the inhaled agents show an excellent correlation with their oil-gas partition coefficient, that measure of lipid solubility again. This link is what really validated MAC as a clinically relevant measure of potency, even as the underlying theory shifted away from just lipids.
So the unitary hypothesis, the idea that all GAs work the same way, like messing with the whole membrane that got rejected, what took its place?
The shift was towards the agent-specific theory. The current understanding, the consensus really, is that different GAs likely use different molecular mechanisms, although there's certainly overlap in their targets.
And the target isn't the bulk membrane anymore.
No. The focus now is on specific hydrophobic domains, sort of oily pockets on crucial membrane proteins, or perhaps the interface right where the lipids meet these proteins. These proteins are the actual molecular switches that the GAs are flipping.
Okay, so now we're getting specific. And the anesthetic state itself isn't monolithic, right? Different parts happen in different places.
Exactly. It's a fragmented effect. Unconsciousness, that loss of awareness, seems to be primarily mediated by actions in the thalamus or the reticular activating system, which are key hubs for consciousness.
Right, the brain's on switch.
Pretty much. Then amnesia, the memory loss, that's linked more to effects in the cerebral cortex and especially the hippocampus, the brain's memory consolidation center.
And immobility, the thing MSC measures.
That resistance to movement when there's surgical pain, that's largely happening down in the spinal cord.
Fascinating. Okay, let's dive really deep now into those molecular targets, these protein switches in the CNS. We're talking mainly about ligand-gated ion channels.
Yes, they are the major players. And arguably the single most important target for a wide range of GAs is the GABA receptor.
GABA being the main inhibitory neurotransmitter in the brain.
Exactly. GABA calms things down. Many GAs, most of the inhaled ones, the barbiturates like cypentone, the benzodiazepines, propofol, they all potentiate GABA's action. They make GABA work better.
And how does making GABA work better cause inhibition?
The GABA receptor is fundamentally a chloride ion channel. When GABA binds, or when these drugs help GABA bind more effectively, the channel opens. Chloride ions, CeLO, which carry a negative charge, flow into the neuron.
Making the inside more negative.
Right, causing neuronal hyperpolarization.
Yeah.
This moves the neuron's membrane potential further away from the threshold it needs to reach to fire an action potential, an electrical signal. So it inhibits the neuron, makes it harder to excite.
But critically, these drugs aren't just mimicking GABA, are they? They're not binding where GABA binds.
That's a key distinction, absolutely. They bind to their own different sites on the large, complex GABA receptor protein. They act as allosteric modulators. They change the receptor shape slightly, making it more sensitive to the GABA that's already there.
So they enhance the natural system.
Mostly, yes. Though it's worth noting some agents, particularly barbiturates and maybe some inhaled agents at high enough concentrations, can actually directly open the chloride channel even if GABA isn't present.
Okay, so GABA covers sedation, maybe amnesia. What about the immobility aspect down to the spinal cord?
For immobility, another key inhibitory receptor comes into play, the glycine receptor. This one is very prominent in the spinal cord and also the brain stem or medulla.
And it works similarly.
Yes, it's also a chloride channel. Its inhibitory action is boosted by agents like barbiturates, propofol, and many of the inhaled anesthetics. Enhancing glycine inhibition in the spinal cord is thought to be crucial for blocking the motor response to painful stimuli, producing that immobility MX measures.
So we've got boosting the brakes, GABA, and glycine. But you mentioned some GAs work differently by hitting the accelerator.
Exactly, or rather by blocking the accelerator. This is where drugs like nitrous oxide and ketamine come in. They don't primarily work on GABA or glycine. Instead, they selectively inhibit an excitatory receptor, the NMDA type of glutamate receptor.
Glutamate being the brain's main go signal.
Precisely. The NMDA receptor is a channel that lets positive ions, especially calcium, Ca, into the neuron when glutamate binds. Blocking this channel prevents that excitatory influx, making it harder for the neuron to fire. This is the main mechanism for N2O and ketamine. Interestingly, most of the volatile inhaled anesthetics don't seem to affect NMDA receptors very much.
So different tools for different jobs.
Yeah.
Enhance inhibition or block excitation. Is there another major target type?
Yes, there's growing evidence for the role of certain potassium K+ channels, specifically a family called 2-pore domain K+ channels, or K2P channels. Some GAs seem to activate these channels.
And what happens when you activate potassium channels?
Potassium ions, Ca, carry a positive charge. Opening these channels allows Ca to flow out of the neuron down its concentration gradient. Losing positive charge also makes the inside of the neuron more negative, contributing to hyperpolarization and inhibition. This can be particularly effective at the presynaptic terminal, reducing the release of neurotransmitters.
So putting it all together, GABA, glycine, NMDA block, K+ channels, the common theme seems to be messing with communication between neurons.
That's the fundamental point. GAs work primarily by depressing synaptic transmission. They interfere with the process of one neuron talking to the next. This is a crucial difference compared to local anesthetics, like lidocaine, which work by blocking the electrical signal, the action potential, from traveling down the axon of a single neuron. GAs target the junctions.
Okay, that distinction is clear. Now let's step back from the molecules and look at the overall effect on the patient. GAs cause this descending depression of the CNS, right? Higher functions go first.
Yes, it's typically described as an irregularly descending depression. Consciousness, cognition, judgment, those higher cortical functions are affected first. Then motor control, reflexes, and finally the vital centers in the brainstem, the medulla, which control breathing and circulation, are depressed last, thankfully.
This progression is what led to the classic description of anesthetic stages, wasn't it? Whittle's 4 stages, based on ether.
That's right. Arthur Goodell described these in the 1920s, based on observing patients slowly induced with ether. Now, with modern, faster drugs and pre-medication, we often kind of zoom past stage 2, the excitement phase. But Goodell's stages are still the conceptual foundation for understanding anesthetic depth.
Let's quickly walk through them because they are fundamental. Stage 1.
Stage 1 is the stage of analgesia. It starts from the first breath of anesthetic until the patient loses consciousness. They might feel woozy, dreamlike, maybe disoriented, but they're still technically awake, can respond. Pain sensation diminishes progressively, and amnesia starts setting in. Clinically, you might use this just for very short, minor things, maybe with N2O.
Then comes stage 2, the one you want to avoid lingering in. The stage of delirium or excitement.
This is the tricky transition. It goes from loss of consciousness until breathing becomes regular and automatic. It's marked by paradoxical excitement. The patient might struggle, thrash, hold their breath. Muscles can become rigid. You see signs of sympathetic overdrive. Heart rate and blood pressure can shoot up, pupils dilate. The absolute rule here is no stimulation, no surgery during stage 2. It can provoke dangerous responses like laryngospasm. The goal is always a smooth, rapid transit through this stage.
Got it. Pass, go quickly. Stage 3 is where you want to be for the operation, surgical anesthesia.
This is the target zone. It starts when regular automatic breathing begins and extends down to the point where spontaneous breathing stops altogether. Goodell actually divided this into 4 finer planes.
4 planes within stage 3. How did he distinguish those? What signs was he looking at?
Primarily eye signs and reflexes. Plane 1 starts with regular breathing. The eyeballs might be roving around, moving randomly. This plane ends when the eyes become fixed, usually looking straight ahead. Plane 2 is deeper. You lose key protective reflexes here, like the corneal reflex, the blink response when you touch the cornea, and the laryngeal or gag reflex. Respiration is still good.
Plane 3.
Dipper still. The pupils start to dilate, and they stop reacting to light. Muscle relaxation becomes more profound. Respiration starts to change. The intercostal muscles between the ribs become weak, so breathing becomes mainly diaphragmatic, more abdominal.
And plane 4 is getting close to the edge.
Yes, plane 4 is very deep surgical anesthesia, total paralysis of the intercostal muscles, leaving only shallow belly breathing. Cardiovascular function starts to get significantly depressed, blood pressure falls, and the pupil is widely dilated.
You're bordering on stage V here.
Which is stage 4, medullary paralysis.
This is overdose territory. Breathing stops completely, apnea, followed rapidly by circulatory collapse and death. The pupils are fixed and widely dilated. Modern monitoring prevents us from ever reaching this stage intentionally. So given that modern drugs like propofol for induction or sevoflurane for inhalation get you through stages I and II in basically seconds, and we often use muscle relaxants which paralyze the patient anyway, those classic Guidel eye signs aren't always reliable now. How do modern anesthetists monitor depth to make sure the patient isn't too light, risking awareness, or too deep?
It's a combination of things. They look for residual reflexes if the patient still has an eyelash reflex, a flicker when the eyelash is stroked, or swallows. They're likely too light, maybe still in stage 2. Loss of response to a painful stimulus like firm pressure on the bone above the eye socket suggests adequate depth, likely stage 3.
And responses to the surgery itself.
Absolutely. A sudden rise in heart rate or blood pressure or an increase in breathing effort when the surgeon makes the incision, those are reflex responses indicating the anesthesia is too light. Conversely, a significant drop in blood pressure and severe respiratory depression are signs of being too deep. It's a constant balancing act, monitoring these physiological signs.
This fine control absolutely depends on getting the drug concentration right in the brain, which brings us squarely to pharmacokinetics. The journey. Lungs. Blood baning. How fast does it get in? How fast does it get out?
It's all about partial pressure gradients and how quickly equilibrium is reached between these compartments. Several factors control this speed. First, the inspired gas partial pressure. Basically, the concentration you dial up on the vaporizer.
Higher concentration means faster induction?
Yes, especially at the beginning. You often start with a higher concentration to load the system quickly, driving the drug into the blood faster because the gradient from alveoli to blood is steeper.
Second factor, breathing, pulmonary ventilation.
How much air, and thus anesthetic, the patient moves in and out per minute. If you make the patient breathe faster and deeper, hyperventilate them, you deliver more drug to the alveoli per unit time.
Does hyperventilation speed things up for all inhaled agents equally?
It has the biggest effect on agents that are highly soluble in blood, like ether used to be, or halothane to some extent. Because the blood acts like a large reservoir for these drugs, it takes a lot to saturate it. Increasing ventilation helps fill that reservoir faster. For poorly soluble agents, the blood saturates quickly anyway, so ventilation has less impact on the speed of induction, though it still affects delivery. Importantly, ventilation rate affects how fast you reach a certain depth, but not the final depth itself.
What about problems with the lungs themselves?
Right, alveolar exchange. If there's a mismatch between ventilation and blood flow in the lungs, like an emphysema or with a pulmonary embolism, the transfer of gas from alveoli to blood is inefficient. This slows down both induction and recovery because equilibrium is harder to achieve.
Okay, but you mentioned solubility in blood. You said that's really the main dial controlling speed.
It's arguably the most important intrinsic factor for the drug itself. We quantify this with the blood. Gas partition coefficient, often written as lambda. Think of it as how much the drug likes being in the blood compared to being in the gas phase in the lungs.
So high solubility, high lambda.
A high lambda, like for ether or halothane, means the drug dissolves readily in blood. The blood acts like a huge sponge. You have to dissolve a large amount of drug into the blood volume before its partial pressure in the blood rises high enough to drive it into the brain.
Result, slow induction, slow recovery.
Exactly. Conversely, an agent with a low lambda, like nitrous oxide, desflurane, or sevoflurane, doesn't dissolve well in blood. The blood sponge is small, it saturates very quickly, the partial pressure in the blood rises rapidly, matching the alveolar partial pressure, and the drug quickly crosses into the brain.
Result, fast induction, fast recovery. Makes sense.
It's the key determinant of the speed of onset and offset for inhaled agents.
What about where the drug goes after the blood and brain, especially during long surgeries?
That's tissue solubility and redistribution. GAs are generally lipid soluble, so they distribute to all tissues, but especially to fat. Fat tissue has a lower blood supply than the brain, but a huge capacity to store these drugs.
So for a highly fat-soluble drug like halothane,
During a long operation, hours long, it continuously accumulates in the body's fat stores. When you turn off the vaporizer, the concentration in the brain drops relatively quickly because blood flow washes it out and it redistributes to other tissues initially. The patient might start to wake up, but the drug then leaches out of those fat stores very slowly, potentially for hours, which significantly prolongs full recovery and can cause lingering sedation.
And the final piece is just getting it to the brain efficiently. Cerebral blood flow, CBF.
Yes, the brain receives a very high proportion of the cardiac output, so it's perfused extremely well. Delivery is rapid once the arterial blood concentration rises. An interesting clinical point, you can actually manipulate CBF slightly. Inhaling a small amount of carbon dioxide, CoAROs, causes cerebral vasodilation, increasing CBF. CoARO also stimulates respiration. Both effects can technically speed up both induction and recovery, though it's not standard practice now.
Before we compare the specific agents, we absolutely have to cover those unique N2O effects, the second gas effect and diffusion hypoxia. They sound quite counterintuitive.
They are kinetic phenomena related to using N2O at very high concentrations, like 70% or even 80%, which is common because it's not very potent. Let's take the second gas effect first. This happens during induction.
Yep.
You start giving high concentration N2O because N2O has very low blood solubility, low lambda. It rushes from the alveoli into the pulmonary blood incredibly quickly in massive volumes, maybe 1 liter per minute or more.
So a huge volume of gas is literally leaving the lungs and dissolving into the blood each minute.
Exactly. This rapid uptake of N2O effectively shrinks the total gas volume remaining in the alveoli. To compensate for this volume loss, fresh gas mixture from the breathing circuit gets sucked into the alveoli at a rate faster than the patient's own breathing would provide.
So the N2O uptake creates an extra flow, concentrating whatever else is in the alveoli.
Precisely. It concentrates the second gas, the potent volatile anesthetic like sevoflurane or isoflurane that you're giving concurrently at a much lower percentage. This concentrating effect, plus the increased total inflow, raises the partial pressure of that second gas faster than expected, speeding up its induction. It's a kinetic boost provided by the N2O.
Clever. But then the reverse happens when you turn it off, and that's dangerous. Diffusion hypoxia.
Yes, this is the risk during emergence. When you stop the N2O, the process flips. N2O rapidly rushes back out of the blood and floods into the alveoli, again because of its low solubility and the steep gradient now favoring exit.
So the alveoli fill up with N2O coming out of the blood.
Right. This massive outflow of N2O displaces or dilutes the gases that should be there, primarily oxygen and CoARO. The dilution of alveolar oxygen can lead to a significant drop in the patient's blood oxygen levels, causing hypoxia, especially if they are breathing room air at this point or have any respiratory compromise.
How do you prevent that?
Simple and standard practice. Administer 100% oxygen for several minutes immediately after discontinuing the N2O. This ensures the alveoli are filled with oxygen, counteracting the dilutional effect of the outpouring N2O.
Got it. Crucial safety point. Okay, let's use these properties now to compare the actual inhaled agents in use today and maybe contrast them with the historical ones.
Let's start with the one we just discussed, nitrous oxide, N2O. Its defining features, very low potency. Its MAC is over 100%, around 105%, meaning you simply cannot achieve surgical anesthesia with N2O alone at atmospheric pressure without causing severe hypoxia.
But it's a fantastic pain reliever.
Excellent analgesic properties, yes. Even just 20% N2O gives pain relief comparable to a standard dose of morphine. And because of that very low blood solubility, onset and recovery are very rapid, very smooth. It's non-irritant, generally non-toxic in short-term use.
So its main role is as a helper drug.
Primarily used as a carrier gas for the potent volatile agents and as an adjuvant, adding 50–70% N2O allows you to significantly reduce the concentration needed of, say, sevoflurane, often by about 1/3, which minimizes the dose-dependent side effects of the potent agent.
Are there downsides or warnings for N2O other than diffusion hypoxia?
Yes. If used for very prolonged periods, like days in an ICU setting, which is rare now, it can interfere with vitamin B12 metabolism by inactivating methionine synthase. This can lead to bone marrow depression and even peripheral nerve damage.
And the trapped gas issue.
Critically important. N2O diffuses into air-filled cavities in the body much faster than nitrogen diffuses out. So if a patient has a pneumothorax, air trapped around the lung, or trapped gas in the bowel from an obstruction. N2O will rapidly expand that pocket, potentially making the condition much worse. It's contraindicated in those situations. Also, it tends to increase cerebral blood flow, which can be a problem if intracranial pressure is already high.
Okay. Now, the historical contrast. Ether. Potent, but flawed.
Diethyl ether, yes, highly potent, actually provided quite good muscle relaxation too, partly by inhibiting acetylcholine release at the neuromuscular junction. But the downsides were huge. Highly volatile, yes, but also highly flammable and explosive, a major fire risk and operating risk.
And unpleasant for the patient.
Terribly. Very high blood solubility meant induction was slow, often taking 15-20 minutes, and it was pungent, irritating to the airways, causing coughing, breath holding, and copious amounts of saliva and bronchial mucus. Patients needed atropine beforehand just to stop them drowning in secretions. Recovery was equally slow, with prolonged nausea and vomiting very common. It's essentially obsolete in developed countries now, though its simplicity means it might still be found in very resource-limited settings.
Then came halothane, the drug that really started the modern era in '56. Big improvement, but not without its own serious risks.
Halothane was a massive step forward, non-flammable, non-irritant, quite potent, with a reasonably pleasant smell, making induction smoother. Its blood solubility was intermediate, so kinetics were much faster than ether. But its Achilles heel was cardiovascular effects.
Heart problems.
It causes significant direct myocardial depression. It weakens the heart muscle contraction, reducing cardiac output and lowering blood pressure. And crucially, it sensitizes the myocardium to catecholamines like adrenaline. Meaning, if adrenaline levels rise, perhaps due to surgical stress, or if adrenaline is injected locally for bleeding control, halothane makes the heart much more prone to developing serious arrhythmias, abnormal heart rhythms.
But it had one advantage for lung patients.
Yes, it's a potent bronchodilator, relaxing the airways, which made it a good choice for patients with asthma. However, the other major concern was its metabolism.
Liver toxicity.
A significant portion, maybe over 20%, gets metabolized in the liver. In rare cases, particularly in adults after repeated exposures, this could trigger an immune-mediated halothane hepatitis, which could be fatal. That risk, plus the cardiac issues, led to its decline.
And we absolutely have to mention malignant hyperthermia, MH. Halothane was a primary trigger.
Yes, MH is a pharmacogenetic emergency, a rare inherited condition where patients have abnormal calcium channels, specifically the ryanodine receptor, RIR1, in their skeletal muscle. Triggering agents, classically halothane and the muscle relaxant succinylcholine, cause these channels to dump massive amounts of calcium inside the muscle cells,
Leading to
uncontrolled, rigid muscle contraction, generating immense heat, hyperthermia, massive oxygen consumption, CO2 production, and acidosis. It's an acute, life-threatening crisis requiring immediate cessation of the trigger agent and administration of the specific antidote, dantrolene.
Okay, so halothane is largely gone. The workhorse that replaced it for many years and is still widely used is isoflurane. How does it compare?
Isoflurane became the standard. It's less potent than halothane and also slightly less soluble, meaning slightly faster kinetics. The key cardiovascular advantage is how it lowers blood pressure.
Different mechanism.
Yes. While BP still drops, it's primarily due to vasodilation relaxation of blood vessels rather than depressing the heart muscle directly. Cardiac output is generally well maintained. This makes it much safer for patients with heart problems. Plus, it does not sensitize the heart to adrenaline, eliminating that arrhythmia risk.
Other advantages.
Very little metabolism, maybe less than 0.2%, so liver and kidney toxicity are extremely rare. It's also considered safe for neurosurgery as it doesn't tend to provoke seizures, unlike some older agents. Its main drawback is a pungent, slightly irritating smell, which can make mask induction in an awake patient a bit cough-inducing, less smooth than halothane or sevoflurane.
Right. So if isoflurane is the reliable standard, what about the ones designed for pure speed, especially for day surgery? Desflurane.
Desflurane is all about speed. It has an extremely low blood gas partition coefficient, the lowest of the potent agents. This gives it the fastest onset and, crucially, the fastest offset. You can wake patients up very quickly after turning it off, which is ideal for outpatient procedures where rapid recovery is key.
What are the trade-offs for that speed?
Several. It's the least potent, so you need to use higher concentrations. MAC is around 6–7%. It's also very volatile, boiling near room temperature, so it requires a special, heated, pressurized vaporizer to deliver accurately.
And patient comfort.
It's quite pungent and irritating to the airway, especially at the high concentrations needed for induction. This can cause coughing, breath holding, even laryngospasm, so it's generally not used for mask induction. Also, rapid increases in its concentration can trigger a transient sympathetic nervous system stimulation, causing a temporary spike in heart rate and blood pressure.
Any specific safety warnings?
Yes, a concern arose about it reacting with desiccated, dried-out co-absorbent, the soda lime used in anesthesia circuits, to potentially form toxic carbon monoxide. This requires vigilance about maintaining the absorbent's hydration.
Okay. And the last of the modern volatile agents, often favored for kids, sevoflurane.
Sevoflurane strikes a nice balance. It's also got low solubility, giving it fast onset and offset, not quite as fast as desflurane, but much faster than isoflurane. Its big advantage is its pleasant, non-irritating odor.
Making mask induction easy.
Exactly. It's very well accepted by patients, especially children. For mask induction, much smoother, less coughing. Its overall properties are somewhat intermediate between isoflurane and desflurane. Cardiovascularly, it causes some myocardial depression and vasodilation, leading to a drop in BP, maybe slightly more than isoflurane, but less sympathetic activation than desflurane.
Downsides.
Cost is one factor. It tends to be more expensive. There was also some initial concern about its metabolism, although minimal, around 5%. One metabolite was potentially nephrotoxic in rats, but this hasn't proven clinically significant in humans. It does react with soda lime to form a compound, compound A, which was also a theoretical concern, meaning it's generally not recommended for use in very low flow or fully closed circuit anesthesia techniques.
That's a great overview of the inhaled agents. Now let's switch gears to the intravenous anesthetics. You mentioned earlier they're the standard for getting things started quickly.
Absolutely. For induction, that initial transition from awake to unconscious RV agents are typically preferred because they work incredibly fast. We're talking about one arm-brain circulation time.
Which is how long?
Roughly 10 to 15 seconds.
Yep.
You inject into an arm vein, and by the time that blood reaches the brain, the patient is losing consciousness. It's very smooth, avoids that stage 2 excitement that is almost entirely.
And then you often switch to an inhaled agent for maintenance.
That's very common. Induce with RV, maintain with inhaled. Or you can continue with an IV infusion for the whole procedure, which is called total RV anesthesia, or TIVA. The key principle for the rapid offset of the initial RV bolus dose is redistribution.
Okay, let's unpack that with the classic example, the Pioneer 4 agent, thiopentone.
Thiopentone, or pentothal, is an ultra-short-acting barbiturate. It's extremely lipid-soluble, so when you inject it, it floods into the highly perfused brain almost instantly, causing rapid unconsciousness.
But its effect wears off quickly, even though the drug is still in the body. That's the redistribution part.
Exactly. Its action isn't terminated because the body eliminates it quickly. Its actual elimination half-life is quite long, 8-12 hours. The initial awakening happens because the drug rapidly leaves the brain and redistributes into other, less well-perfused tissues, primarily muscle first, and then accumulates more slowly in fat. As the brain concentration drops below a critical level due to this outflow, the patient starts to wake up.
What were thiopentone's drawbacks? Why isn't it the go-to anymore?
Several. It's a poor analgesic. In fact, at low doses, it can even make patients more sensitive to pain, risking laryngospasm or struggling if a painful stimulus occurs as they wake up. It causes significant respiratory depression and can lower blood pressure. And critically, it's absolutely contraindicated in patients with a rare metabolic disorder called acute intermittent porphyria, where it can trigger a life-threatening attack.
So the drug that largely took its place, the dominant IV induction agent now, is propofol.
Propofol diprivan is the current standard for sure. It also works primarily by enhancing GABAA inhibition, similar to barbiturates. Its big advantages are its pharmacokinetic profile and patient experience.
Faster elimination than thiopentone.
Much faster and more complete metabolism, mainly in the liver, leading to an elimination half-life around 100 minutes or so. This means less hangover effect, clearer recovery. Redistribution still plays a role in the initial awakening after a bolus, but the faster metabolism helps significantly, especially after infusions.
And its cardiovascular effects.
It causes a marked drop in blood pressure, often more profound than thiopentone initially. This is mainly due to potent vasodilation, both arterial and venous, although there can be some direct myocardial depression too. Careful dose titration is needed, especially in elderly or hypovolemic patients.
The patients seem to really like it.
Yes, patient acceptability is excellent. Induction is generally smooth, recovery is usually very clear-headed, and importantly, it has antiemetic properties. It causes much less postoperative nausea and vomiting, PONV, compared to many other agents. This makes it ideal for day case surgery and also the cornerstone of TIVIA techniques.
Are there any major warnings with propofol?
The main one relates to its use for prolonged sedation, typically in the ICU setting, especially at high doses for days. There's a rare but serious complication called propofol infusion syndrome, PIS, characterized by severe metabolic acidosis, muscle breakdown, rhabdomyolysis, high blood lipids, liver enlargement, and potentially fatal heart failure. It requires extreme caution with long-term high-dose infusions.
Okay, now for something completely different, ketamine. It produces a state called dissociative anesthesia. What does that mean?
Ketamine is fascinating. It's structurally related to PCP, phencyclidine. Its main mechanism isn't GABA, it's an NMDA receptor antagonist blocking that excitatory glutamate pathway we talked about. Dissociative means the patient seems somewhat disconnected or separated from their environment.
So they might look awake.
They might have their eyes open, they might make involuntary movements, muscle tone can be increased, sometimes rigid, but they are experiencing profound analgesia, pain relief, and amnesia. They're unaware of the procedure even though they don't look asleep in the conventional sense.
What are the big advantages of ketamine?
Two major ones. First, it generally maintains spontaneous respiration and protective airway reflexes, like coughing and swallowing, better than most other GAs. This makes it very useful in emergency situations or in settings where advanced airway management isn't readily available.
And the second, its cardiovascular profile.
Yes, unlike almost all other GAs, which tend to lower blood pressure and heart rate, ketamine typically causes sympathetic nervous system stimulation. This leads to an increase in heart rate, cardiac output, and blood pressure.
Which makes it good for...
Patients in shock, particularly hypovolemic shock from trauma or bleeding, it helps support their circulation. Conversely, this makes it dangerous for patients with uncontrolled hypertension or significant coronary artery disease, as the increased cardiac workload can be detrimental.
What's the main downside people associate with ketamine?
The risk of emergence phenomena. As the drug wears off, patients, especially adults, can experience vivid dreams, hallucinations, disorientation, and delirium, which can be very distressing. This is less common in children. Pre-treatment with a benzodiazepine can help reduce this risk.
Speaking of which, let's talk about the benzodiazepines, BZDs, themselves in anesthesia. They're not primary GAs, but used for sedation.
Exactly. Drugs like diazepam, Valium, lorazepam, atipamone, and especially midazolam, first, are used extensively for conscious sedation, which we'll define shortly, preanesthetic medication to reduce anxiety, and sometimes as part of an induction sequence, although they induce unconsciousness much more slowly than propofol or thiopentone.
Key features.
Excellent anxiolytics, anxiety relief, and potent amnesiacs. They're very good at preventing memory formation for the period they're active. Lorazepam is particularly known for its amnesic effect. However, they are poor analgesics. They don't provide significant pain relief on their own.
Why is midazolam often preferred?
Midazolam is water-soluble, making its injection less painful and irritating to veins compared to diazepam or lorazepam, which require lipid emulsions. It also has a shorter duration of action and faster onset than the others, allowing for better titration and quicker recovery.
And a huge safety feature for benzos.
They have a specific reversal agent, flumazenil. If a patient becomes too sedated, flumazenil can rapidly and completely reverse the effects of the benzodiazepine by blocking its binding site on the GABA receptor. That's a major safety advantage.
Okay, now for the heavy hitters for pain control during surgery.
Yeah.
The opioids.
High-potency opioids like fentanyl, sufentanil, alfentanil, and remifentanil are crucial components of balanced anesthesia. They provide intense analgesia, which allows the anesthetist to use lower concentrations of the inhaled or IV anesthetics, thus minimizing their side effects like cardiovascular depression. They contribute significantly to hemodynamic stability, keeping heart rate and blood pressure steady during surgical stimulation.
Fentanyl is the classic example. Downsides.
Potent respiratory depression is the main concern. It can significantly decrease breathing rate and depth, potentially requiring post-operative ventilation. It can also cause muscle rigidity, particularly in the chest wall at high doses, making ventilation difficult. And it often causes bradycardia, slow heart rate, due to stimulation of the vagus nerve.
But there's an opioid designed for ultimate control. Remifentanil. What makes it so special?
Remifentanil has a truly unique pharmacokinetic profile. It's incredibly potent but extremely short-acting. Its effects wear off within minutes of stopping the infusion.
Why so fast?
Because it's metabolized not by the liver or kidneys, but by non-specific esterase enzymes found throughout the blood and tissues. This breakdown is extremely rapid and predictable, regardless of the patient's liver or kidney function, and doesn't depend on the duration of the infusion. It doesn't accumulate.
Making it ideal for
Situations requiring precise moment-to-moment control of analgesia. You can titrate the infusion very finely to match surgical stimulus intensity and be confident that the patient will wake up quickly and breathe spontaneously almost immediately after the infusion stops. Great for neurosurgery, where you might need rapid neurological checks, or for very long procedures where accumulation of other opioids could be a problem.
Perfect. Lastly, in this section, let's just firmly define conscious sedation and how it differs from general anesthesia.
This is a really important distinction. Conscious sedation, also sometimes called procedural sedation, is a state of depressed consciousness, usually induced with the drugs like midazolam, often combined with fentanyl, or sometimes low-dose propofol. The goal is to make the patient comfortable, relaxed, maybe sleepy, and amnesic for an unpleasant procedure like an endoscopy, colonoscopy, or setting a fracture.
But the key difference from GA is
The patient maintains their ability to respond purposefully to verbal commands and, crucially, maintains their own protective airway reflexes. They can breathe on their own, clear their throat, etc. They are not unconscious in the way a patient under general anesthesia is. It's a lighter, monitored state of sedation sufficient for the procedure, but preserving those vital protective functions.
okay, that clarity is vital. Now let's pivot to the critical aspect of safety, complications, and pre-anesthetic medication. Anesthesia is all about managing risk. What are the common adverse effects we need to be aware of?
Risks exist both during and after the procedure. During anesthesia, the main immediate concerns are things we've touched on. Respiratory depression, common with most agents. Potential for cardiac arrhythmias, especially with halothane or high catecholamines. Airway problems like laryngospasm or aspiration of stomach contents, and significant falls in blood pressure.
And the one patients fear most.
Awareness. Accidental awareness under general anesthesia, where the patient has some perception or even explicit recall of events during surgery, is rare but devastating psychologically. Preventing this is a primary goal of careful monitoring.
And after the anesthetic wears off, what are the common post-op issues?
Nausea and vomiting, PO and V, are very common and distressing. Persisting sedation, drowsiness, or just feeling fuzzy can delay recovery. We also watch for specific organ toxicities like the rare halothane hepatitis we mentioned, or potential kidney issues with certain metabolites, though modern agents are generally very safe in this regard. And increasingly, there's concern about postoperative cognitive dysfunction, POCD.
Cognitive issues, especially in older patients.
Yes, particularly in elderly patients after long major surgeries, there can be subtle or sometimes significant difficulties with memory, concentration, or executive function that can persist for weeks or even months. The exact causes are complex and still being researched, likely involving the anesthesia, the surgery, inflammation, and patient factors.
Safety also hinges on managing the patient's other medications. Drug interactions are a huge area of concern.
Absolutely critical. For example, patients already taking antihypertensive drugs can have an exaggerated drop in blood pressure when combined with GAs that also cause vasodilation or cardiac depression. We already mentioned the risk of halothane plus adrenaline.
What about patients on steroids?
That's a life-saving point. Patients on long-term corticosteroids, like prednisone for conditions like asthma or arthritis, have suppression of their own adrenal gland function. The stress of surgery requires a surge of cortisol that their body can't produce. They absolutely must receive supplemental stress dose steroids, typically 100 milligrams of hydrocortisone, intraoperatively to prevent potentially fatal adrenal insufficiency and circulatory collapse.
And diabetics.
Diabetes management needs careful planning. The stress of surgery and anesthesia typically increases blood sugar levels and insulin requirements. Often, patients on oral agents are switched to insulin perioperatively, possibly an infusion, to maintain tight glucose control.
Okay, so to manage all these risks proactively, anxiety, secretions, aspiration, pain, we use pre-anesthetic medication. What are the overall goals, the aims of giving meds before the anesthetic?
There are generally considered to be 6 main aims for pre-medication. 1. Relieve anxiety and fear, make the patient calm. 2. Produce amnesia for the period leading up to the surgery. 3. Supplement analgesia, reducing the amount of GA needed later. 4. Decrease airway secretions and block unwanted vagal reflexes like bradycardia. 5. Provide an antiemetic effect to prevent PONV. 6. And critically, decrease the acidity and volume of stomach contents to minimize lung damage if aspiration were to occur.
Let's quickly look at the drug classes used for these aims, for anxiety and amnesia.
Benzodiazepines are the mainstay. Diazepam, lorazepam, or often midazolam given orally or IV shortly before surgery. They calm the patient, make induction smoother, and provide that valuable amnesia. Lorazepam is noted for particularly strong amnesia.
Opioids for pre-op pain.
Yes, if the patient is already in pain or significant postoperative pain is expected, an opioid like morphine or fentanyl might be given preoperatively. This contributes to overall analgesia and can reduce the GA requirement. The downsides are potential respiratory depression before the anesthetic even starts, and they can constrict the pupils, interfering with using pupillary signs to gauge depth later.
What about drying agents like atropine? Are they still routine?
Less so for just drying secretions because modern inhaled agents like sevoflurane are much less irritating than ether was. The primary modern use for anticholinergics like atropine or glycopyrrolate is to prevent or treat vagal reflexes, that sudden slowing of the heart, bradycardia, that can be triggered by surgical manipulation, especially eye surgery or abdominal procedures. They can also help prevent laryngospasm.
Why is glycopyrrolate often preferred?
Glycopyrrolate is a quaternary ammonium compound, meaning it doesn't easily cross the blood-brain barrier. So it provides the desired peripheral effects, increasing heart rate, reducing secretions, without the potential central nervous system side effects of atropine, like confusion or delirium. It also tends to have a stronger and longer-lasting anti-secretory effect if that's needed. One caution: anticholinergics can relax the lower esophageal sphincter, potentially increasing the risk of gastric reflux.
Aspiration is a dreaded complication.
Yeah.
How do we protect the stomach and lungs?
This is crucial, especially for emergency surgery where the patient hasn't fasted. We use drugs to reduce the risk associated with aspiration. H2 receptor blockers like ranitidine, Zantac, or famotidine, Pepcid, or more potently, proton pump inhibitors, PPIs, like omeprazole, Prilisac, or pantoprazole, Protonix, are given to increase the pH, reduce the acidity of the stomach contents.
Why is pH so important?
Aspiration of highly acidic fluid, pH below 2.5, causes severe chemical pneumonitis, lung injury. Raising the pH above, say, 3.5 makes the aspirated fluid much less damaging. Sometimes drugs called prokinetics, like metoclopramide, are also used to try and speed up gastric emptying, reducing the volume. The goal is to have gastric volume ideally less than 25 milliliters and pH greater than 3.5.
And finally, preventing that post-op sickness.
Yes, antiemetics are often given prophylactically. The selective 5-HT3 receptor antagonists, like ondansetron Zofran, have revolutionized PONV management. They are highly effective and have a good safety profile, making them the first-line choice for preventing nausea and vomiting related to anesthesia and surgery.
Fantastic. That covers the pre-medication strategy thoroughly. Let's try and wrap this up.
It's been quite a journey through this deep dive. We started with that sort of simple-sounding idea of drugs dissolving in fat, the lipid solubility hypothesis, and ended up discussing specific molecular targets, these intricate protein channels like GABAA and MDA, those two poor domain K+ channels acting at different sites in the brain and spinal cord. It really highlights how anesthesia has evolved into this highly specialized science, managing complex physiology and pharmacology.
And the thing that always strikes me is how incredibly narrow that line is between the desired effect and serious trouble. That dose-response curve you mentioned for inhaled agents, it's so steep. 1 ms stops movement in 50% of people, but just nudging it up to 1.3 MSE gets 95%. Yet doubling or tripling the MSE can be fatal.
That's the reality. It demands constant vigilance, precise delivery, and a deep understanding of all these factors we've discussed. Absolute mastery of the material is essential.
So as we finish, here's something for you, our listeners, to think about. We've seen that the different facets of anesthesia, the pain relief, analgesia, the memory loss, amnesia, the stillness, immobility, seem to happen in different brain regions and involve different molecular targets. Given this increasing specificity, how close are we really to a future where anesthetic cocktails could be personalized, truly customized, based on an individual's genetic makeup and the precise nerve pathways involved in their specific surgery? Where do you think the science is heading?